Okay, well, next up is Robert Singer, who's going to be talking about elective surgery and procedures, what guidance we have for the attendees. Robert.
know, five, everything's changing rapidly. 5 days ago, CDC, American College of Surgeons, Surgeon General, came out with some guidelines that said you shouldn't be doing, or you should think about whether you want to be doing elective procedures, generally suggested that you don't. But a lot of that was really directed at the concept of hospitals and freestanding ambulatory surgical facilities, because it was an issue of supplies and personnel that they could shift into areas where they would need them to deal with patients with coronavirus or ICUs. And that wasn't necessarily the same for office-based, where your personnel wouldn't be going into the hospital. Supplies generally weren't the same. So there was a nebulous area there, and it was really applied more, as I say, outside of the office-based surgery. The Aesthetic Society at that time said you should think about not doing those procedures and deferring them. Now, in the last couple of days, the Aesthetic Society came out with much more firmer suggestions and guidelines that you not do any elective, unnecessary, non-urgent surgical procedures or non-surgical procedures. It's a significant difference. And the reason being the potential of contamination of your staff, and patients. So that has changed from where we were. Quad A does not have a firm guideline. They say follow essentially state and local guidelines and federal guidelines. ASPS has also come out with the idea of deferring any and postponing any elective non-urgent procedures. ISAP's position is think about this. Things vary from country to country. They're really not in a situation where they're going to dictate anything, but they would urge you to postpone non-elective or elective things until later. Next slide, Mark. I'm sorry, let's go on to the next slide, Mark. So in different parts of the country, there was shelter in place, stay at home, stay in place. Those are confusing terms. They mean different things to different people in different areas. Initially, there were cities like New York, Beverly Hills, Santa Monica, San Diego. I'm not going to read all of these, San Francisco, who said, okay, we're going to put in this shelter in place. Essentially, we don't want you outside for anything other than absolute necessities or jobs that are absolutely required for the benefit of the community. Since that time, there are state shutdowns. New York, California, Illinois, Texas has a patchwork, Connecticut, New Jersey, Pennsylvania, Oregon. The last Oregon, Ohio, I added in the last 2 days, Louisiana late yesterday, and Kentucky and Delaware today. So I think you're seeing there's an extension of this, a progression, and more states are going in that direction with the idea of flattening the curve. We have a lot of international members who, of over 1,000 who registered for this. And with internationally, China has had essentially a shutdown. Denmark, El Salvador, France, New Zealand, Poland, Spain, Ireland, although the rest of the UK has a little different philosophy. Germany is considering it, but they're concerned about the economic aspect of this. I think we're going to see more and more countries who are coming up with that same approach as the number of cases has vastly increased. Next slide, please. So when concerns about doing the procedures we do in elective cosmetic procedures, what's the risk to the patients? Not only from surgery, but we know that there is an immune response from anesthesia and surgery with a decreased immune response right after. Also, there are a number of follow-up visits, the exposures coming into either your office or hospital setting for those. What's your staff exposure? And I know there are a number of my staff who said, I'm not comfortable doing this at this point. And your anesthesia provider. There are a number of cases that have been reported, high rate among ENT people or plastic surgeons who are doing rhinoplasties, who are doing endoscopies, and with intubation. The other thing to think about is, although you may be limiting the number of patients coming in and the contacts, the anesthesia provider that you have coming in, they may be over at the hospital a lot of times. They may be in the ER. They may be doing other things. And what is the potential exposure you're going to get from them to your patients? Non-surgical, non-urgent elective procedures, again, similar risks, similar immune response, the number of follow-up visits, and the staff exposure. There's a tremendous exposure when you're doing fillers, when you're doing neurotoxins, you're up in the facial area. The potential exposure to you and your patient and your staff are huge. Is it worth the risk? Because what happens if you've gone through everything, you've explained it to them, they've signed an informed consent, and now they have a problem? How are you going to deal with that? How is that going to look in your community? And even though you may have all of that written out in your informed consent, there's nothing more creative than the minds of the plaintiff's attorneys. The other thing is, if they have that problem, and I'll go with that with the next slide. Let's go on to the next slide. So right now, we haven't set a sunset for the moratorium that's come out in the guidelines from the Aesthetic Society. I'm not sure we realistically can set one. It would probably be worthwhile to come up with a potential date, knowing that that's a moving target and may have to be altered. Once you resume your doing procedures and surgery, what should the screening be? Should everybody be tested for COVID-19 and beforehand? Because you may be operating on them, they may have that, they may have not shown the symptoms for that. Should the limitation be older than 60? We know that's a greater risk factor, but the reality is, in the group 20 to 44, 20% of the admissions with COVID-19 have been within that age group of 20 to 44. So they're not exempt, although there's greater risk in the older group. What about patients with comorbidity, hypertension, diabetes, sleep apnea, obesity? Increased risk, should you be operating on those patients at this point? What about if somebody lives with an immune compromised individual? Once you start resuming your surgery, thought should be given to the type of patient. Do you want to limit it to ASA 1 or 2 and the type of anesthesia? Is it different? Do you feel, and is there a greater risk with general than intravenous sedation that's monitored? I don't think we have necessarily the specific answers to that, but you need to think about yourself and your own practice. What about the length of surgeries? Longer cases, combination cases, should they really be done at this time? And what about a case with a planned hospital admission that you would normally have done in your office and then admit electively to the hospital? Taking up those beds in the hospital that may not be available, are you better off postponing those surgeries to a different time, or doing a procedure or not doing a combined procedure that will take a lot less time, where you're not going to be planning on admitting them? And what happens if there's an unplanned post-procedure admission? How are you going to deal with that? How are you going to explain that to the family, who may be very concerned or angry, and the patient, and also the hospital if they don't have a bed available, or they're going to be taking up a bed that potentially, because they have a problem, they have COVID-19, they're going to be going to the emergency, they're going to go to the ICU. How do you explain that? How do you explain that if it's tomorrow morning on the front page of the New York Times or the Wall Street Journal, why you did this case? I'm not taking a position that it's right or wrong for you, but there's more than just the guidelines. There is the ethical, moral position that we have in the community of whether we should doing that. And I think each of you have to make up your own mind on how to do that. I've decided not to do elective procedures or surgery at this time until we have more understanding of where this COVID virus is.
Thank you, Robert. Great presentation.
Thank you.
Share with us what your conversation was with the doctor's company today, please.
Okay, I call it doctor's company because everybody has those concerns. If you are doing a case, and we've already had guidelines from College of Surgeons, CDC, and the Aesthetic Society, if you're doing a case and there's a problem, are you still covered? Doctor's company said yes, you have the coverage and the underwriting for your practice. The second issue is if you're not actively doing surgery and you've closed your office for a couple weeks or a month, will doctor's company give you some rebate on that? And they say, no, you're being covered as a physician. You may get sued during that time for other cases that you've done. There is not a reduction in your fees for that. The other thing I asked about is, well, there are a lot of offices that are running into trouble economically. We've had some vendors in industry give a grace period of a longer period of time rather than 30 days or 60 days to pay those bills. Is doctor's company willing to do that? They said that normally they would give like 30 days, but they will do that on an individual basis if you call in and explain to them what that means. Will they'll give you longer period of time without canceling your insurance? I couldn't get a specific answer, but it sounds like it's a work in progress, that they're adapting to the environment now and may be more lenient about that. But again, that's one carrier. I can't speak for the others. I haven't had a chance to speak to them. I think that each of you need to speak to your own carrier and find out. And I think Mark is going to talk about some of these things in the next talk.